Welcome to this edition of Be Live. We are live on Facebook Live. This time, our discussion is African men's sexual health. And we are lucky and privileged to have two experienced guest speakers. We have Dr. Edwin Mapara, a very experienced doctor in infectious diseases, including HIV. He has worked in Africa, Namibia, Botswana, and Zambia, most of the Southern Africa, I should say. He's a writer of education, and a lecturer at one time at London School of Hygiene and Tropical Medicine. Say hello to the audience, Dr. Mapara.
Thank you, Bwana Badru, and greetings to the audience. I'm humbled and I look forward to this presentation and to sharing experiences. Thank you.
Good, great. We have Mr. Takuzwa Mkiwa, popularly known as Taku. I remember when I spoke to somebody about Takuzwa Mkiwa, I said, who is that guy? Then when I said Taku, he said, oh, he's our Taku. So he's the head of social marketing at THT, Terence Higgins Trust, and he was formerly head of HIV Prevention England project at THT. This is a England-wide project which he was managing. Say hello to the audience, Taku.
Hello to everyone. Thank you so much for this opportunity to have this discussion, which I am actually very excited and looking forward to. Thank you.
So, great. And my name is Badru Malay. I am the HIV Prevention and Testing Coordinator at Positive East. I'm also the lead on community engagement, so working with communities. I'm the host of the discussion today. We are on Facebook Live, as I said, where we have a big audience. Please, anybody on Facebook, share this discussion. It is very important for our community. Please send your questions to the panel of experts in the chat room at Facebook Live. We'll be ready, and I'm sure the guests will be very, very excited to answer your questions. Now, what is Positive East? Positive East is East London's leading community-based HIV charity, providing better future for people living with HIV or affected by HIV. The mission of Positive East is a world where people living with HIV can fulfill their potential, free from stigma and discrimination, and live full, healthy lives. Again, Positive East is committed to the Fast Track Cities target of eliminating HIV by the year 2030. Annually, nearly 2,000 people living with HIV walk through the doors of Positive East and access vital support services, counseling, mentoring, and also join Positive East to volunteer with us. Prevention team conducts about 2,500 free rapid HIV tests every year out in the community to reduce, with the aim of reducing actually late diagnosis and onward transmission. Now, looking at our topic today, men's sexual health.
Yes.
HIV testing is a very, very important prevention and transmission activity, and is important part of HIV combination prevention. In the year 2019-2020, Positive East conducted about 2,659 HIV tests, and only under 8% were African. On the national scale, nationwide, the rate of late diagnosis amongst Black African heterosexual men rose to 69%. You know, from 2015, it was about 59%, and within 2 years, it rose to 69%, which is very alarming. And in contrast to the overall late diagnosis rate, which has fallen, you find this one very, very disturbing. The high percentage of undiagnosed HIV among this group, the African men group, puts individuals to a greater risk of transmitting HIV to others as they are not on treatment because they are undiagnosed and cannot make informed decisions about their sexual behavior. So this is a very, very important issue that we are going to discuss today because it shows that there is a need really to understand why is that so. Why are African men diagnosed later? What are the barriers? What are the challenges faced by African men when communicating with their sexual health needs? What can be done to educate and involve African men in better managing their sexual health? So these are the things we are going to look at, and they are very, very important. And I think because we've got the two experts with us today, it is the time really to go to the core foundation of these reasons why there are barriers. Now, Dr. Matpara,
Yes.
how prevalent are HIV and STIs among African men?
Sadly, they are very prevalent. And in fact, the figure that you stated of 59% going to 69%, when I saw it the first time, I was alarmed. Say, am I seeing properly? To check two other books just for this figure. Because definitely African communities, we make about 1.8% of the adult population. That's Africans. And if you talk about these figures, you're talking of in 2014, of those who were diagnosed, it was 34%. When you're talking of 2019, 59%, 69%, that is alarming. And unfortunately, amongst the population of people living with HIV, is roughly about 105,000 altogether in the UK. And of these, it is stated that about 6,000 are diagnosed annually, let us say. And of those undiagnosed, 12% undiagnosed are African men. 4% are African women. Yeah. So when you compare the ratio, it is alarming, it is frightening, it is not good news at all.
Well, are there any particular sexual health issues that impact on men more than women?
We have, and in fact, when you're talking about the sexual issues, apart from HIV, where it is very alarming, we've got these other common infections. And you're talking here of, first and foremost, chlamydia. You're talking of gonorrhea. You're talking of syphilis. You're talking of human papillomaviruses. These are the common ones, although there are many others. But sadly, out of these thousands, in fact, when I was looking at the figures, I was trying to put down a tally, although I could not differentiate the white folks and the black folks. But just to show you, chlamydia in 2018, we were talking of roughly 518,000 infected. Gonorrhea, 80,000 per year. Human papillomavirus, you're talking of close to 60,000. And with these figures that you stated of 69% diagnosed for HIV, I mean, a number of these sexually transmitted infections are double. Where you have HIV, you may have chlamydia, you may have gonorrhea. In fact, in the past, I've had some patients who came in with syphilis. And on examining them, it was syphilis, gonorrhea, HIV. So amongst the African men, it is frightening. And others, you also talk of hepatitis B, hepatitis C. And for African men, testing for this, it is rare, it appears. Why? We don't know. And like you say, I hope by the end of this hour, we shall have a solution as to how we can reduce these figures. It is alarming when you're talking about close to 70% being infected.
Yeah, so I think this is the right time now to talk about this because even the sexually transmitted infections that you have mentioned, some people have never heard of them and they don't even think about it. So this is the time really to make sure that people do understand and do the needful to come out and care about their sexual health. Now, my brother Taku, my young brother,
Yeah.
are there cultural differences, any differences in culture of how African men talk about sex and sexual health?
Well, like I think one of the things which is there is we have a complex situation. Like I want to talk about sort of my experiences working with African men, because I have found sometimes there are differences amongst us African men. So
Yes.
before I even talk about African men against other groups, but just amongst us African men. So one of the things, for example, is when you look at the experiences of HIV, they're different dependent on which African country sometimes maybe somebody might have come from or they're affiliated to. So I wouldn't want to maybe put culture at the front, but I would want to put experience at the front as well when it comes to HIV. So the experience, for example, I'm from Zimbabwe. The experience of Zimbabweans is that it is rare for you to find somebody from Zimbabwe who maybe grew up during my time, like that is sort of in the 90s, early 2000s, who would say to you they don't know somebody who died as a result of getting maybe AIDS. Like if they don't know anyone close, it's either they were totally cocooned from society or they're lying to you. So it's either those two options. So what I see is from the experience point of view, there is this sort of a history of us having people being afraid of dying of HIV. We are no longer there. We are no longer there. But so it makes people still be afraid to talk about HIV now because of an experience, which is a true experience of bad experience of HIV some time back. It's no longer the same right now.
Okay.
So, yeah, so experience over culture initially, and then in terms of behaviors around what we do, maybe we can talk about culture.
Yes.
Yeah, and you said that the differences in culture has no effect on the way people consider their sexual health, or do you mean to say that it is the experience that models the way they think about their sexual health?
So like one of the things that I want to say, for example, what I have experienced, like when it comes to HIV, people
Yes.
are afraid, like in terms of their, it's not a cultural thing that they don't want to maybe talk about HIV. Sometimes it's actually much more the experience with HIV, maybe from the past, which makes them less likely to talk about it. But when it comes to the cultural side of things as well, there are things which are sort of beneficial in terms of our cultures, in terms of how we talk about sexual health. From a Zimbabwean point of view, people here sometimes the idea is parents should talk to their children. In Zimbabwe, parents never talk to their children. You talk to your uncles. Yeah. Your uncles were there to do that, like in terms of like sort of the issues around sexual health. But of course, we are here, the structures are no longer the same. The structures are no longer the same, and it makes it we don't have the same ways of talking about it. So to some extent, we are left with the options of talking about our experience, like talking about sexual health through the education system, through our peers. And so it's then the question of like how the peers frame how you talk about HIV. And my experience is sometimes your peers frame it not necessarily from a cultural point of view, but from their experience point of view and whether they've accessed the information or not. So culture plays a lot in terms of how we behave, I find, like in terms of how maybe how we link up with sexual partners and everything. It will play a lot around that. But how we talk about it, experience I find sometimes is a big thing, like because I can tell you that I've had so many conversations. One which sticks out with me is when I said to somebody, well, look, Taku, why are you talking to me about this HIV stuff? You know, when I got to Heathrow, Africa stayed on the plane and I entered the UK. And, and I said, what do you mean? And he was like, well, you see, I don't worry about HIV in the UK the same way I worried about it when I was in Africa, because in Africa it was in my face, like from their experience then. But because they don't see as much here, maybe in the main media, people then don't talk about it. They don't think it's an issue as when they compare to back, like maybe back to Africa, maybe. So that's where the experience comes in. But how people behave, that's where we've got cultural issues to talk about.
That's right. That's right. You hit the nail on the head, because what I know is that African men can easily talk about business, politics, football, but reluctant to talk about their sexual health. I don't know whether, in certain corners they do, but that's what you have just said. That's what I hear. But why is it so? Why do you think it is so?
I don't know, Dr. Mapara, if you want to step in as well here, yeah.
Yes, no, definitely I'd like to come in, because what you said is very, very true. And having worked in Southern Africa, what I noted, if you come from a good family,
yes,
do you talk about sex? No. If you come from a good church, do you talk about sex? No. If you talk freely the way we are talking about sex, people will say, who is that who was brought up poorly from a bad family? In a church, you don't talk about sex, you don't talk about relationships, unless you're a bad Christian, so to say. So I think the way we're socialized in Africa has been a disadvantage for us who have come here. That even for the colleagues who are here, I've been to sessions where people say, doctor, you can't say that. And I say, but why not? We're talking about sex. We're talking about the penis, we're talking about the vagina. In fact, my name, Mapara, is in between the legs. And people would say, what? And I would use that now to talk freely about sexual relationships, talk about sexual intercourse. So the way we're socialized in Africa has been a disadvantage to us in Africa and even here. And that's why when we come here and you find the young people talking freely
exactly
about sex, even your children talking to you about their girlfriends, and you say, in Africa, there's no way to tell daddy, I'm going to see my girlfriend. I'm going for a sleepover. I mean, obviously, the sleeper or the plane will be waiting for you.
Well, I think, sort of to add on to that, this is, I think, where we have sort of one of those challenges, like most of the times, why I talked about peers, I would say sometimes guys amongst guys, one of the things which has been amazing, I would say, is WhatsApp groups. So in WhatsApp group, I'm in a number of WhatsApp groups with other sort of Black African men like myself, and there's plenty of those groups, and people do talk about sex there. For example, they will talk about sex because I think it's perceived to be a safe space to talk about it without it being sort of an embarrassing sort of place to talk about it. So the challenge that we've got is that sometimes peers talk to each other about sex, but sometimes my worry is whether there is amongst the peers, if there isn't somebody with the knowledge which is sort of maybe up to date with stuff in terms of what is being shared amongst peers. And how do we, for example, people who work in this field, how do we ensure that people can continue having that peer-to-peer conversation, but have the information that they need? Because the thing, like Dr. Mapara said, is there is sometimes, when we introduce it as a formal conversation, it is embarrassing for many people because there isn't that sort of familiarity with it. But people use some of these spaces to talk about it. And the challenge is, how do we enable people to talk about it with information? Because I can't tell you the amount of times myself in groups that I'm part of where I have to be correcting information. And I'm talking amongst people who you'd think maybe they know about stuff, but but I'm having to correct information that, look, if you've got HIV, you get onto treatment, you'll be fine. And people well, what do you mean? And I'm just, well, treatment works. Treatment works. The best thing that you need to do for yourself is get diagnosed early, and then you get onto treatment. but people are not necessarily aware of that, like all those things, but they do talk about sex. And it's the things about conquest. People talk about it in the sense like, oh, you know what I did last night? And I'm just like, okay, you try to find an opening for us to talk about, yeah, when you did it, did you think about your health and the other health?
Yes.
Absolutely. Absolutely. I remember talking to a group of young African guys, and they told me that for us, you know, in our age group, the more partners you have, the more sexual partners you have, the more macho you look, you know, the more you start to boast about how many girlfriends I've had in 1 year and things like that. But again, they don't talk about sexual health. Why are African men, let me say young and old maybe, don't really come forward? Because this is the problem. Why don't they come forward to sexual health screening or even have an HIV test? Is it the information, as Taku said, is it because of the safe spaces, as Taku said? Is it really, because some of them are born here, really? Yes. And the thing about Dr. Mapara said that if you're from a good family, don't talk about sex and this and that. Now, this generation here is quite different, but it is also the same like the first generation. They don't come forward to test. What do you think are the issues?
On that one, when I was thinking about it last night, I just said, I'm going to provoke the audience, our listeners, so that they can come in with solutions from these questions I'm going to ask. Because for us who've been in the field, we've done so much, we ask ourselves, goodness, from 34% to 69%. What have we done wrong, or what haven't we done? So I put down a list here and I said, is it one, the cultural change, the cultural isolation, that even here in the UK where we are, you will find the Zambians have got their own organizations, the Ugandans, the Zimbabweans, South Africans. That link is not there. So you might find that Ugandans have got very good AIDS programs, but talk of colleagues from other countries, they don't even have one support group. They don't even know what you're talking about. That is one. Is it the language barrier? When we talk about the language barrier, is it about the English? Are we using the right media to communicate to our people? I spoke to one group in London, where I was shocked when I was told, where we come from, doctor, we do not show those pictures, because I believe that teaching with pictures, people see what we're talking about. So those men told me, even our biology, when we were taught about biology, we don't see the pictures of the penis or the vagina. It is taboo. Then I said, hold on. But when you're talking about it, you must see these parts. What about diagrams? They said nothing. So it was the first time we were learning about the human anatomy. And these are the adults we're talking about, not teenagers. Then there's a question of, is it the literacy levels, the educated versus the uneducated? Is it the issue of primary school, secondary school, college, or university? Are we not giving out the message? Are they not grasping? Do they still believe there's no problem? The question of the economics, especially for the adults, they'll tell you, look, we're in this country is to make money. There are bills to be paid. There's a rent issue. I cannot attend these workshops unless there's something in it for me. Is it to do with the church, the faith communities, where some faith communities still believe you don't need the ARVs or the antiretroviral therapy? Prayers will do. We shall heal. We shall put hands on you. So those questions come in. Is it to do with the technology? In fact, I'm happy that Taku talked about the WhatsApp, because what I noted, true, people are freer on those chat groups, especially when you know yourselves, it's just a men alone. Are men intimidated speaking in public, speaking where there are women? So these are some of the questions. Then the term of, when we're teaching, are we using the right methods? Talking about academic models and pragmatic. And what I mean here, I've attended a few workshops where the teaching is so much of handouts and technical science information. Then there are others where you sit down and say, oh, I've seen these pictures, doctor, that you, Badru, and William used to teach. I've learned so much, and I've attended 10 other workshops on AIDS before I did not understand. So our teaching methodology, a picture is worth 1,000 words.
I don't know if I can, I don't know if I can also jump in there, like Badru. So I think one of the things which has been interesting is about creating opportunities actually for people to test. So we come from a culture where most of the times, like we're talking about men in general, we've got a tendency of not going for health checkups anyway, whatever man you're talking about, whether African or not. Men, we've got a culture of not going to get tested, checked for anything to do with our health. And linked to that is just the idea, as somebody says it, if it ain't broken, why fix it? So when it comes to HIV, we have a challenge because most of the times when people sort of perceive of maybe getting ill, they think, you see symptoms, you know immediately that you're not feeling well, therefore you go to your doctor. But our challenge here is with HIV, we know that people who are getting diagnosed late, and that means on average, the people who are getting diagnosed late would have had HIV for between 3 to 5 years without knowing that they've got it. So I think the thing to emphasize to so many men most of the times is that this idea of saying, if I get it, I will know, it doesn't work that way. It doesn't work that way. The only way to know for sure is for you to get tested. So I think that is one of our challenges when it comes with HIV and people coming forward to proactively test. Most of the people that we're talking about, we've got a huge percentage of people who are getting diagnosed. But they're getting diagnosed because they were now really ill with something. And then the doctors are just like, okay, let's test for that. Let's test for that. Have you tried testing for HIV as well? And then they find that it's the HIV. But I think what our challenge is how to ensure that we encourage people to test more regularly. And by regularly here, test once a year, or that's quite a good thing. Or if you change sexual partners, test as well. And I think that is the thing. So in terms of creating opportunities, I think, but we've worked together. So some of the work that we've done of going to football events where men sort of get tested. What has been interesting for me is we go there, the men, they know they're coming to football. We tell them in advance that we'll be testing for HIV. When they get there, some of them is like, okay, we said to them, would you like to test? And then they say, oh yeah, I'll do it. But when you then have a conversation with that individual, say, if this test opportunity wasn't there today, would you have tested? They're like, well, I wouldn't have thought about it. So I think, like Dr. Mapara said here, it is a challenge on us to create more opportunities for people to test. Because they, sometimes it's not that they don't want to come forward, they just haven't thought about it. They've got rent to think about. They've, like you said, they've got money to send home to think about. They've got so many other things on their minds. And especially when HIV particularly is something which then doesn't immediately sort of give you symptoms. It's the last thing on their on their mind. And so I think what the statistics that we're talking about at the beginning, just enabling men to understand that actually we do have a problem. I think the estimate at the moment is across England, there's about 400 undiagnosed men, Black African men, about 400. So they have HIV, the estimate that they don't know they've got it. So if we get tested, we have such a good opportunity to do it. So the challenge is community chats about it, but also on us providers to make sure that people have more opportunities to test at the most convenient times to them when they can, rather than relying on them walking in to come and do it.
And if I, could I add on to that? Yeah. That's very true that right now as we talk, the women have more opportunities of testing by virtue of going to the hospital for their breast screening, the pap smear screening for cancer, the issue of family planning, the issue of pregnancies. So any of those 4 routes, one can go for HIV testing. But for the men, we don't have those kind of services where every year you're going to go for this. And then also just to add, I think for the men, if there was a way to tell them, Once you go to the hospital, ask for an HIV test. You'll be surprised how many will say, but doctor, I've been going to the GP for the last 2-3 years with the same problem. Nobody asked me for an HIV test.
Yeah, yeah.
And it was only by chance when somebody says, oh, look, you got this rash. I also had the rash. This rash might be HIV. Go and tell the doctor. Then you go to tell the doctor, said, oh, somebody told him this rash, this shingles might be HIV. And then also, not belittling the doctors here, a number of our doctors do not know the signs, the symptoms when it comes to HIV testing, HIV screening. And then there are some who are afraid, thinking to be racist.
Yeah.
If Edwin moves in and I say, Edwin, can I do an HIV test? Why me? That other white person didn't ask them, you know? So there are these challenges. But to tell our men, when you go to the clinic, ask for an HIV test. Some will tell you, I went, they did the blood test. Said, no, not a blood test. Say, doctor, with a full blood count you're doing, the test you're doing, can I have an HIV test also?
Yeah.
Many people do not know an HIV test is special. So it is up to us to get to our people to say, guys, this is a situation.
Yeah, that's absolutely. Now, to go back to Dr. Mapara, you briefly talked about the STIs. And we know that STIs affect men and women in a different way. But what are the common STIs to look out for men? Maybe there may be telltale signs that you might have, HIV or something like that. And can you tell us about the symptoms and those STIs that don't have symptoms?
Very, very good. In fact, I liked your introduction at the beginning when you said there are some people who don't know about some of these sexually transmitted infections. In fact, all in all, we are talking of more than 26 types of sexually transmitted infections. There are even new ones that are coming up, which I learned of only last night. So if we talk about chlamydia, unfortunately, a number of our men believe chlamydia is only for women. Not knowing chlamydia affects both men and women. The adverts, when they go out, we must make sure chlamydia shows that it's for men and women. And for the men, most of the times, there's nothing that shows. You might get a slight discharge. Then later on with time, there might be a bit of pain when passing urine. So that is the thing about chlamydia. When we are talking about gonorrhea, it is very common amongst our men. And in fact, right now they are saying it is quite a big issue amongst the gay community of men having sex with men. With gonorrhea, from past experience, when I was in Zambia, Botswana, we had clinics 2 days after a weekend. And do you know why? A clinic on Tuesday and Wednesday, because it meant on Saturday, these one-night stands, if people did not use protection, it is automatic for men. Within 72 hours, so to say, more than 80% will come to the clinic on Tuesday or Wednesday. Doctor, my urine is burning. Doctor, I've got a leak. And already when they say it's burning, you say, Chief, what happened over the weekend? And they'll tell you, Doctor, the one-night stand, this is the issue. And I say, that's why I'm asking about the weekend. Because gonorrhea, you cannot hide it.
Yes.
If you're going to hide it, it means you won't be drinking water for the next couple of days. Because once you drink water, you must go to the test. So with gonorrhea, the issue of pain, that's a major thing about gonorrhea. It's very painful. Whereas for the women, you might find it's not even painful at all. And that's why it's important, bring in your sexual partner. Because later on, for the ladies, they might end up with a complication of infertility. They had gonorrhea, which was not treated. It was not their fault, but the men's fault. They never told their partners. Then you've got the issue of syphilis. It was a condition which was going down, but now we're beginning to see more and more cases. In fact, if I recall, last year there were about 6,000 new cases of syphilis. And with syphilis, the thing about it, it has a sore or a chancre or a pimple on the penis. We're talking about the men here, which is not painful at all. And sadly, because it's not painful, people don't come to the clinic. And when they come, you'll find that the ulcer on the penis has grown to the size of a 50p coin. And you say, but Bwana, what happened? Why did you take so long to come? You say, doctor, this thing is not painful. And that's the thing about syphilis. And I always tell the men, remember, S for syphilis, S for silent. It is not painful at all. So with syphilis, that is a major issue. If it's not treated, the complications can be severe in terms of heart disease, kidney disease, the liver being affected, the brain being affected, the bones and the skin. So these are some of the complications for these common ones. And then there's what we call human papillomavirus, HPV. And with HPV, you're talking about genital warts. And these warts can be on the penis. These warts can be in the anal region. And we've had situations where men did not know they had anal warts. Because with HPV, it has an affinity for the foreskin of the men, those aren't circumcised. HPV has an affinity for the anal region. And that's why it's important for our men. We must examine them when they go to the clinic to say, but look, if he presents with syphilis or a genital rash, genital warts, the penis must be examined, the anal region must be examined. There are some men where we examine the anal region and say, but chief, you've got these warts here. Doctor, what are you saying? And because they can't see their back, they did not know, because these are not painful. So that's the thing about HPV. So these are the common ones. I'll leave it there for the time being, but definitely we know once you get a sexually transmitted infection, 50% of the time, there might be no sign, no symptom. But otherwise, passing of burning urine, a penis discharge, whitish, brownish, sometimes reddish, an ulcer on the penis or genital warts, lower abdominal pains. All those are some indicators that you might have a sexually transmitted infection. And for the men is to emphasize, once you have an STI, get your partner or your partners treated. Because once you are treated and they are not treated, when you go back, there'll be a what? Reinfection. So those are the common presentations of most of the sexually transmitted infections. And mind you, nowadays you've got anal sex, oral sex, vaginal sex. We've had people presenting with gonorrhea of the mouth. We've had people presenting with herpes of the mouth, herpes of the penis, herpes of the anal region.
Anal region.
Yes. Yeah. So these are some of the issues that we have to address.
You're right. You're right. Just recently, I was in a discussion with the people from Southeast Asia as well, and we've got, mostly they are mostly Muslim people, and because of the Islamic culture, women have got to get married when they are virgins. But in these circumstances, this modern life, people start a relationship before marriage, and they have sex. How do they have their sex to preserve their virginity? They have anal sex. And when they go to a sexual health clinic and they check themselves and they declare themselves heterosexual, the anal side is not checked. So these are the missed opportunities where they could find that somebody has a certain STI or not. So I think what you are saying, Dr. Mpara, is quite very, very important. Now, we talked about combination prevention, because now we are privileged to have so many ways in which we can stop HIV being transmitted. And one of them is using pre-exposure prophylaxis. Now, Taku, what do you think there is a lack of awareness and uptake of PrEP amongst African men?
So one thing that I usually like start with on this topic is to say we can't expect people to use something that they don't know about. So, I think in terms of like education around PrEP, there has been sort of a travesty, if I call it that, mainly because I think it has taken quite a long time for us to have sort of lots of education on PrEP happening across sort of Black communities, like African communities. What has happened is there hasn't been enough investment to make the community aware. So I would like to sort of go back to part of the earlier conversations that we had. For
Yes.
you to believe that you're going to use PrEP, just to explain maybe to people what PrEP is first, maybe. So PrEP is HIV prevention drug. You take it when you're HIV negative and it stops you from getting HIV. But it's actually an antiretroviral drug. So for you to actually trust that you're going to use PrEP, in the first instance, you have to trust that HIV treatment works. You won't just start going to use PrEP if you don't trust that HIV treatment works. So I think as a hurdle, people don't know about it. Some people who've heard about it might have mistrust of it. Just because it's there, it doesn't mean that people actually want to use it, like or have to use it. Like I have to. So like we've got the challenges of like of actually it's once it's there, people need time to understand more about it. So the thing is, so maybe the comparison most of the time, which is done, is to say, but gay men are using, like sort of gay men are using PrEP much more. And I'm just like, bro, we have to understand that when we did the trials here for PrEP, when we did the PROUD trials, it was done with gay men. So the education around the concept of PrEP amongst gay men in this country started happening around 2012 when the PROUD study started. And so there was lots of work which happened in terms of actually getting the community ready of understanding PrEP. As soon as PrEP was proved to work, there was lots of media amongst the gay media to say, well, this thing works and it's amazing. So the gay community had an earlier opportunity to know about PrEP. And because I was actually there, like during the time of the PROUD trial, I actually helped with some of the recruitment for the PROUD trial at the time. I know where we were back then, and how long it took for us to actually get lots of gay men trusting in it in the first place. We've not had the same opportunity with African men. So it is not the fault of African men. It is the fault of the system which has not served them well for them to consider using it. I don't think they've had enough of an opportunity to fully consider it, because I don't think there are enough men who know about it to fully consider using it for us to make a judgment whether African men are up to using it or not. We just know that the numbers are low at the moment. And also what we know is we've done lots of research. Like we did a campaign which is called PrEP Protects, which was aimed at raising awareness amongst African communities. When we're doing that, I know we talk to many organizations who work on this issue. Everyone agrees on one thing, that levels of awareness of this thing is so low. So I don't think we are at the point of having serious conversations about uptake. we can see that uptake is low, but when awareness is so low.
That is it. In fact, just coming in, what you said is 100% correct. I've had sessions where I've tried to encourage some African men to take PrEP. You know, some of our colleagues, you know, they touch here and there, and after a drink, maybe they've gone off with somebody. And you try to talk to them and say, look, why don't you take PrEP? Then that your person. Are you saying PrEP? Many have not heard of PrEP, but they know about the post-exposure prophylaxis, PEP. They even ended up correcting me, say, oh no, doctor, I think you made a mistake. You're talking about PEP. I said, no, I'm talking about PrEP.
Exactly.
So like you say, Taku, it's 100%. I mean, our people don't know about it. In fact, I read one of your research, was it? The impact, where apparently of the people that you talked to, only 4% were African men.
Well, but this is the thing about impact, though. This is the problem about impact. Impact trial came in, expecting uptake, like from African people without the education. So impact was basically bouncing off from where we'd gone with the proud study. So it was basically in a way already engineered in a way that made it that it was always going to have lots of subscription from gay men. But the thing which is actually one thing that I really want to point out as well is like the gay population in this country is more active on prevention in general. Like it is much more active. So even when it comes to testing uptake, PrEP uptake, the rates are much higher. So sometimes I want to be careful to always just compare, because I think when we compare, sometimes the communities will react differently. We need to understand the dynamics of some of our populations in terms of why they wouldn't do it. So one of the things which I think has changed now, but one of the major differences that we had amongst our communities was that you used to get lots of I'm married, why should I care about this, from lots of African men, for example. I'm married, why should I care? You talk to the young people, and my frustration has always been is I understand that you want me to talk to the young people, but the people who are more likely to get diagnosed with HIV in this country are actually slightly older Africans. They're not young ones. So, within that age range of people who are married, who tell you that they don't need to think about these things because they are married, they go to church as well. So they are super protected by going to church and being married somehow. So I think with PrEP, we have an opportunity, because I think the opportunity is to get people to understand something about HIV treatment. It's actually, you can, in terms of people who are negative, getting PrEP can stop them from getting HIV, but also to understand the importance of that. Now people who've got HIV who stick to their treatment and actually achieve something which is called an undetectable viral load, where basically the level of the virus is very low. They don't pass on, they can't pass on HIV. They can't do it. It's physically impossible, because the science has shown that HIV treatment works so effectively. So PrEP, our understanding of PrEP is part of the whole mix of treatment and the use of medicine in preventing HIV. I know when it comes to people living with HIV not being able to, it's a byproduct. The primary concern is to make sure that somebody is healthy. That's why they take the medicine. That is why that. But we know as something along that is that there is a benefit as well, that it means that HIV is not passed on. But if there's anyone who is thinking about PrEP, I think we've got, we actually have a tool on the website, which is called startswithme.org.uk. If you go there, there is something which is called a PrEP tool. It helps you just think about PrEP, whether PrEP is the right thing for you. Because what we have to explain to people is, unlike maybe condoms, of course, you can just take them around and then you use them. PrEP needs, you need to understand how it works, because it has to be taken correctly for it to work. It's not like a morning after pill, which is something which is just like you take it and then it doesn't work the same way. So you have to, first of all, understand how PrEP works, and then and it's in simple terms, you can take it as a daily pill. That's the easiest way of understanding that you do it. But you still have to also plan, to take PrEP.
And in fact, Taco, already what you said to me, that is a workshop on its own. That you get African community, just what you've been talking about was somewhere. But when I explained to them how you take the PrEP 2 to 24 hours before, and then after the encounter, then they said, we didn't know. So the lack of knowledge amongst our people is what has destroyed us. And up to now, that 69% I'm still thinking about is saying this is not good news at all. It's an indicator, in a way, that we have failed our people as health promoters.
Absolutely. Now, yes, it is good we have discussed so many issues, and it looks like we still have a lot to do. Taku, you talked about the resources. We don't have enough resources. We don't have enough resources, maybe in terms of funding. We may not have enough projects targeting our men. What projects have you seen or been part of in the past? You told us about It Starts With You, but again, what other projects have you been part of, Taku or Dr. Mapara, either of you? You know,
so I'll be quick about
men.
it. Yeah, so like so the first thing that we talked about, for example, I've been working like for nearly 11 years now with African Nations Cup UK, which is a football tournament organized by African men, and from that that tournament we've worked together nearly every year. We've run testing together, so we've done that in partnership with Positive East. We've done it like with many other organizations, but we go and test the men there, and like at the peak of it, we would test, like per tournament, we'd test up to 200 African men, which is, I think, absolutely amazing. And we have actually collaborated as well with Arsenal TV's Kelechi. Kelechi has been, like for those who know Kelechi, Dr. Kelechi, like from Arsenal TV, he's been an amazing champion of promoting like testing amongst sort of African communities in general, but like also with a focus on men. For those who follow sort of Afro beats and everything, we've worked with Smaid. Smaid, who's been who's a promoter. He organizes Afro Nations and he organizes quite a lot of events, and he's a promoter. He brought Davido over here. He also uses lots of his platforms as well to promote testing. So with some people would also know Adeshope, like Shupsi do. He also promotes that. We work with lots of radio stations, African radio stations, like across the UK, where they also sometimes try to talk about these issues, like on some of their programs. So there are many projects that have happened, but what I want to sort of highlight is the work really, which is being done by people like within the communities, who are not necessarily your traditional health promoters, but the people who've got the platforms to actually reach lots of people. Because I would say one of our challenges as health promoters, we feel so good about ourselves, but sometimes we don't have the reach that we need. Yeah. So we feel we're so important and so good at what we do, but we actually don't have the means to get into people's attention, to get many people to listen to what we're saying. So I always find it's actually useful to have those collaborations. So like we worked with DJ Abbas, Abbas Tijane, like he's an organizer as well, like Nigerian organizer of so many things within the community. And most of the times, yeah, he does stuff, like he will do stuff that I can assure you many of our organizations can try to do because they've got the expertise, but they wouldn't be able to do because he's got the platform to actually reach to the people. And he, over the years, has become sort of a voice that people now also expect to hear something to do with HIV from. And even though he's known for his music and everything, but
is he based in Brixton or something?
No, I don't know exactly where. Like I usually do some work with him, like nearly, like he works from a studio near Canary Wharf. So like like that's where we usually. I think he's based in the East actually. So like yeah, but he does lots of things. So he works with lots of the Nollywood stars and everything. But community organizers, this is what I will say. Sometimes I say this and then people feel like I'm being a bit critical, but sometimes I switch off from the HIV sector when I'm trying to look for solutions, and I say, actually, yeah, you know about HIV, but maybe you don't know about the people. Let me let me talk to the people who know about the people, and then we help them with the HIV to talk to the people. So, yeah.
Are these people we call the community champions?
Well, like this, yeah, like the problem is yeah, you could call them community champions. They are some of them they are organizing all the time. So like I'll call them community champions. Some of them are just influencers who also like can step in and do something. And all these people will have different impact on these different communities.
Mm-hmm.
So sometimes I'll say there are people who are saying, I just want to raise awareness, for example, about something. And they're good at raising awareness because they've got such a huge maybe following of people. And then there are people who I'm just like, actually, I want more engagement than just raising awareness. And those are the people I look at who manage to get conversations going a lot with lots of people. I look into those. And then there are people like DJ Abbas, for example, the work that I do with DJ Abbas, most of the times I know that DJ Abbas will promote something and you actually get lots of people, for example, ordering testing kits to do at home. He can do that. It's not just awareness. He will actually get you the result of talking to people to get people to actually test. So I think they come in different forms, the community champions or whatever you call them, but they have different ways they can contribute to this. So our role sometimes is supporting them, have the conversations around this. Like with PrEP, we worked with DJ Billy from Uganda. DJ Billy, like actually, one thing which was interesting with when we did PrEP, lots of people were sending him messages, for example, to a point where DJ Billy said, Taku, I can't answer all these questions. I'm going to send you the questions and then you give me the answers. And then
because that is how you network, you know, that is how it's supposed to be.
Yeah.
and that's why for me, I always say one spider's web cannot tie up a lion, but many spiders' webs, which you've been talking about, can tie up the strongest lion, you know?
Yes.
No, you've done quite a bit. And for me, I won't even spend too much. I'll just talk about one organization I worked for. This is Community Health Action Trust with Badru and William, where we set up the voluntary counseling and testing.
Yeah.
It would be very unfair if I don't mention Dr. Brooks. What's his first name? Gary Brooks.
Gary Brook. Yeah.
Yes, Dr. Gary Brook. He's the one who blessed Community Health Action Trust to go ahead with the first voluntary counseling and testing center. He came over, he saw what we're doing, and he says, guys, go ahead. It's a wonderful initiative for the community. We started that program, and I'm happy to say with Badru and William, it spread across the country.
Yeah.
That is an achievement which I say, Dr. Gary Brook is a silent, the unsung hero.
Yeah.
He gave a blessing. You know?
Thank you.
So that is one. And then working with HACO in Gillingham, Kent, they've also got a similar program to do with voluntary counseling and testing. And I've worked with a number of communities where I've gone around with my pictures talking about sexual health. And from those communities, I've learned so much. And quite a number of them have said, these pictures talk on their own. And that's why I say, when I go out, I want the pictures to talk. Because from the pictures, you get the community talking. You get the men talking. We even had one man who says, Doctor, that rash you showed, the herpes zoster, I've had it 3 times. And nobody told me it was HIV. Had I known, I could have saved 1, 2, 3, 4.
Yeah.
So I had a chance to go there and say, let's talk about shingles, herpes zoster, and the dermatomes. Doctor is talking jargon. Put a picture of herpes zoster. Say, that one, I've had that rash. Some even lift up the shade and say, can you see? Here it is. This was the first one. This was the second one. Already you've got your diagnosis. So I've been privileged to meet a lot of communities out there, African communities, and we've shared with the pictures. So that's my experience of teaching in the community.
Yeah.
And I just want to say there's so many fantastic organizations across the country who are working out there. I think so. I always advise people, if you're in a particular place in the country and you're not sure, just Google. Just use Google. Sometimes locally you find some local services, like in different parts of the country. There are many organizations. I know that they are fewer than they were before, but there are still some. Yeah.
Thank you. Oh, this was a very interesting discussion. Thank you very much. Thank you, our panel, Dr. Mapara, my young brother, Takuzwa Okiwa Taku. And thank you, Alex, for supporting us technically very well. I thank the audience that have joined us and listened to us. Also, I support everybody who has supported this event to happen today. So we've reached the end of it. For more information, you can visit our website, www.positiveeast.org.uk, or you can call in 0207-791-2855, option 3, which takes you to the prevention, HIV prevention team, or you can email us at prevention. I've forgotten. You can email us at prevention@positiveeast.org.uk. Thank you very much. It was quite interesting, and definitely I'll get good feedback. And thank you, thank you, thank you. We've come to the end of this session. Thank you, everyone. And
thank you very much too.
Enjoy the rest of the weekend.
Thank you.